Hello, my name is S.Reis. This is my video submission for the Level 1 New Graduate RN position at North Canberra Hospital. So to start us off, recognising when something is out of my scope, typically that would be something that would be out of my education, so something that I've either never done before or only ever done on placement under supervision. Typically that would then mean that I would go to my CDN, CNC, or a senior RN that I'm working with for guidance to either how to perform the task or to the CHS policies around that task, making sure that everything I do is safe and within my scope of practice. Secondly, ensuring safe medication practices and what I would do if there's an error. Typically, how I ensure safe medication is following the 8 rights, so making sure it's the right person, right dosage, right route, right reason, right amount, right kind of medication in general, and questioning when I think there might be an error. So if there's 2 doses for the same medication, maybe the doctors or medical team forgot to get rid of one, and questioning that before just administering it without checking. If an error did occur, first priority would obviously be my patient safety, so reversal agents or doing something to kind of minimize the effects would be the main priority, and then also following the CHS policies, monitoring my patient and making sure that a risk met is completed to ensure this doesn't happen again. If my allocation was those 4 patients, my priority would be patient B with the chest pain, with symptoms for the chest pain. Calling for assistance and medical assistance from the medical team would be the first priority to ensure their safety and stabilization. Once that medical team's kind of in there and taking care of the patient, I would then go to patient A, just because I don't want them to have a fall, so preventing that falls risk and keeping their dignity, getting them to the bathroom is most important for me. While they're in the bathroom, I would assess patient C's chart to see if there's anything I can quickly give for nausea. If not, asking the medical team if they can chart something for her nausea just to make her comfortable. And then my lowest priority would be patient D. In that situation, I would either call radiology if possible and get them to delay the CT, or see if my buddy RN is free to do the escort for me, but I believe delaying it would be the best form of care for that patient, especially because it's not urgent. NHQS standards in everyday practice. Obviously, while I was on placement and while I work at a hospital now as a ward clerk, keeping evidence-based practice is always the main thing that I do while I'm on placement, maintaining infection control through PPE, doing everything I can to ensure my patient safety, and everything is quite a high priority. Communicating with the multidisciplinary team and other RNs to make sure that there's no open ends to any kind of communication, and ensuring that everyone knows what they need to know from me and that they're not missing any key points of information about my patients. A situation that I faced while I was on placement one day was I had a patient with a chest tube for a pneumothorax, and he was on a PCA for the pain for this one. He called the call bell. He wasn't my patient, but he was under my group with my 2 RNs, so I went and answered the call bell for them because they were both busy. And his respiration rate was very depressed through a quick assessment. His eyes were doing a quick neurological. He wasn't responding how he was. His GCS had declined and everything, and so when that happened, I pressed the emergency button and got my RN, and I quickly handed over to her what happened and how I thought that he had PCA respiratory depression and he was at risk of not breathing. She agreed. The medical team came, I communicated that to them, and they began the process of reversing that PCA and get everything sorted. While they were doing that, my RN delegated to me that I would be the communication for the family, so getting the family involved and telling them what's going on and telling them what we have to do and what we're doing to ensure our safety and their safety, and they were all pretty on board, escalating his care to ICU, and thankfully he was as okay as he could be after that situation. But keeping that communication and that awareness for all the patient, ensuring my safety, the medical team's safety, and his safety was the most important thing for me at that time. And I feel that that kind of shows the CHS values the most for what I've experienced. Thank you so much.